Hi, welcome to another episode of Talking with Docs. I'm Dr. Paul Zalzal.
And I'm Dr. Brad Wiening.
And I'm Mike Heffernan.
Dr. Mike Heffernan is a cardiologist, and we are so fortunate to have him here today. We were able to peel him off the golf course to come and talk to us today about some cardiology issues. Okay, so today we're going to talk about what happens when you're referred to a cardiologist. Okay, what's that encounter going to be like? Okay, you might be sitting there going, oh boy, I was referred to a cardiologist because I had some chest pain. What's going to happen? What's this visit going to be like? So let's take it from there.
Sure, and I understand that there's anxiety, right? You might be waiting a few weeks, you might be waiting a month before seeing us, and so hopefully this will help to a degree. So number one, when you come to an office like this and your family doctor has reported that you've had some unusual chest pain, not chest pain, by the way, that's been bad enough to say, look, you've got to go to the emergency department right away. This is chest pain where they're not really sure, doesn't really sound like heart pain, but they can't completely know for sure. So we'll send you to the cardiologist to help sort that out.
And is that a relatively common sort of referral?
It is.
Okay.
It is. And so first thing we're going to do is, of course, we're going to greet you. We're going to try and make you feel comfortable, and we're going to do a history. And the history and me listening to your story is going to be the most important feature, because there are some things that you're going to say that are going to make me think, yep, this is absolutely heart pain. We have to take this very seriously and go forward, or this is extremely unlikely to be heart pain, and we'll provide some reassurance.
So it's a combination of their story and then some very pointed questions that you would ask.
Absolutely.
Yeah.
Okay, give us three quick things that make you think, oh boy, this is
sure
hard.
So that it is hard. Okay, so I've got this crushing. As soon as they put a fist like this, rather than a finger, so they go, yep, it's a crushing discomfort.
Okay.
It feels heavy. They use words like heavy, pressure, tightness, and they start to say it's here. They don't say, oh, it's a single dot right there, but it's kind of more diffuse. That makes us concerned. So that's number one. Number two, if they say, yeah, you know what? It also happens every time I do something. Whenever I take the garbage out, whenever I go up a flight of stairs, this comes on and it gets worse. It's more severe.
Sometimes I get annoyed when I take the garbage out. Is that the same thing?
Yeah. And you say, you asked your partner, can you take the garbage out instead?
That's right.
So,
I'm getting chest pain.
Yeah.
Okay.
So exertion. So if exertion brings this on in a reproducible way, and then when you stop, it goes away. That's a big red flag.
Okay, those are three good things on history. Those are two.
Kind of 2.5. And then there are some other things that can kind of come into play. So if you get sweaty, if you feel nauseous, if you're lightheaded when these things are coming on, or your heart is racing at the time, then that's definitely things that we worry about. And then that would lead me then to start ordering other tests. Okay. And the tests can be as simple as a treadmill test to look for abnormalities on the ECG, the dots that we put on your chest and the paper that kind of scrolls off, to something as invasive as an angiogram. That was one of the pics I sent you.
Right.
An angiogram where
the
stock pics, yeah. Where we put a small a puncture either in your wrist or in your groin, and fish a small catheter up into the heart, squirt some dye down the arteries of the heart, and find out if there's a blockage there. So the tests that we can do can range from a simple treadmill test to a nuclear test to a CAT scan to an invasive test like an angiogram. We have a lot of tools in the toolbox.
Mike, would those tests typically happen the day of the consult? I guess depending where you are, maybe it would, or the severity?
So generally not the day
Right.
of. The treadmill test, that sort of thing, that could happen very quickly and can be the day of.
Yep.
Something like a CAT scan or an angiogram is usually a few days later or a week or two later.
Okay.
Yeah.
One thing I've noticed too, our viewers will know that we always say whenever we discuss the thing, we always go history, physical examination, tests.
Yes.
But with more and more virtual medicine, obviously the physical examination is a bit tricky. So we just go history, that's all we can do virtually, and then order some tests, and then eventually bring you in for a physical exam. But now in this encounter, let's say you are fortunate enough to have a face-to-face with the patient,
right,
and not a virtual encounter. What kind of things do you do on physical exam? You've taken a history, you're going to do a physical exam of this patient that's come in. What kind of things are you looking for there?
Yeah, so we're looking for their heart rate.
Okay.
So is it too fast? Is it too slow? Looking at the blood pressure, well controlled or maybe not well controlled. And then listening to the chest, are there signs and symptoms of heart failure? that might be going along with something. Perhaps a patient had a heart attack a few weeks ago, and we can kind of get some clues as to whether that happened. And then we're listening to the heart, and we're listening in particular for abnormal heart sounds.
What's that thing?
Yeah, I know. As a surgeon, you wouldn't be familiar with this.
That was a reflex there.
So we're listening for abnormal heart sounds. Maybe there's a valve problem, for instance, and something else that might be going on.
And that's a skill that I think the average patient probably doesn't appreciate. Like, this thing can tell so much information about your heart, and it's really, really subtle. When we're in medical school and in training, you listen to hundreds of different people, and half the time, especially at the beginning, you couldn't really hear it. And then someone would kind of guide you saying, to hear this extra little sound, and then you're like, okay, well, that means this valve's closing at this rate. And yeah, it's an amazing skill, and it's a critical part of the test.
And it's called a stethoscope.
Yeah.
So just in case anyone out there is wondering.
Yes.
And it's a device that's more than 100 years old.
Amazing.
And really, it's quite elegant.
Yeah.
Okay, so you're going to go see your cardiologist, and he or she is going to take a history, a physical exam. If it's an in-person thing, will happen, and then tests will be ordered, and then presumably then you'll make a diagnosis, say yes, this is cardiac origin, or no, this is not a cardiac origin.
Yep.
And then determine a treatment algorithm based on that.
Right, and the test really, I say in my letters to the family doctors who made the referral, the test is going to dictate what we do. It might be, congratulations, Mrs. Smith, you have normal coronary arteries, don't have to worry about it. Or I'm sorry, Mr. Rogers, you've got blockages in all three of your main coronary arteries, you need an angioplasty or bypass surgery.
Just lastly, for the patient when they are getting prepared, is there anything that you would advise them to do, say at home the night before or even weeks before?
Oh yeah.
What could they do to be more prepared and to make the visit more useful for both of you?
Most important thing is bring your medications.
Okay.
Not even a list. If you can bring the bottles, we're happy to go through it. It's a really important thing, especially if you're coming into the office and you already have some other diagnoses.
Yes.
If you have high blood pressure, you have diabetes, you have other things that kind of are going on in your life, I need to know the medications you're on. It also changes how I feel about the story you're about to tell me. If you've got some other risk factors, I might be more worried. So bring in your medications. If you have the ability to do your blood pressure at home, it's really nice when people can do that and take some control over your health that way.
Yep.
You can bring in some sample readings. Then I don't have to believe the reading I get in the office because I know you're going to be upset.
Sure.
White coat syndrome. That's what
syndrome.
you've heard of that, where when you're in the doctor's office and they measure your blood pressure, it's much higher than typically it is when you're at home, relaxed, just because you're a little bit anxious because you're in the doctor's office, right?
And so those home readings trump whatever I get in the office.
So medications, blood pressure, and then maybe do you ever encourage them to journal, say, hey, when did you get the chest pain? What were you doing? Try to keep track. I had it Tuesday and then I had it Thursday night.
Yeah, to a degree,
okay,
but not to a point where it's so neurotic that
takes over your life.
Takes over your life.
Go back to scrapbooking, right?
Okay, that's an awesome summary. So you guys know what to do now. Be prepared for your visit. The cardiologist is going to go through many different things, including a physical and some investigations, and get you on the proper path for your heart. If you like this video, please like it, subscribe to our channel.
And again, thank you very much. We're going to drop you
Dr.
back off on the 11th hole from where we kidnapped you to come and do this.
Yes,
Okay?
that's right. Thanks.
Remember, you are in charge of your own health.
We'll see you next time.